Hi, I'm Jacob Lang, optometrist at Associated Eye Care in the Eastern Twin Cities. I'm joined today by Cecelia Koetting,
Hi, Cecelia Koetting in Denver, Colorado at the University of Colorado.
and we're going to talk a little bit today about intraocular lenses, lens implants, and our patients. So Cecelia, lens implants have come a long ways from when we started the original, cataract surgeries and things like that. Where do you see lens implants in refractive surgery?
So I'm definitely seeing, yes, we've got a whole lot more options at this point. And so therefore, because we're having more options, patients are getting better outcomes, and I think surgeons are also then feeling more comfortable with doing more refractive IOLs as far as even just an exchange versus having cataract surgery.
Right. So do you feel like cataract surgery is really a refractive procedure now?
Yeah, I do. I feel like it is. There's a lot more expectation from the patients as well as the surgeons, as well as us as optometrists on the other side when they come back to us. We do, I think, are holding it to a higher standard. So I think it's almost become more of not an elective procedure, but kind of viewed in that same light.
Mm-hmm. Yeah, so cataract surgery, when there's true lens opacity, patients still have a lot of expectations. And
Yes.
that's probably some generational shifts. And their friends that have gone through it and had good vision, and so they have these experiences. What other things you think has changed kind of why patients feel like they want to see better with cataract surgery after cataract surgery?
Well, our lives are going longer. We're living longer. We're retiring later. We're being more active. Even if you're not working, just the visual demands that we have with being on the computer, our phones, all of these things that require us to be more, they're just more visually demanding.
Sure.
Yeah.
Sure. You mentioned surgeons and surgeons having opinions and doctors of optometry having opinions as well. Everyone has an opinion, right?
Yes.
So how do you feel like with co-management and integrating care between a surgeon and an optometrist, what are the best ways to communicate and work alongside, build this team of eye care providers to best serve our patients?
Yeah. So I've been very lucky to be in a position where I worked for a number of years in a clinic that's what we did. And even though we had optometrists within, we still co-managed with our all of our doctors, all of our optometrists in the area. They had the option. If they wanted to be a co-managing doctor, they could. And now we as a clinic were more proactive as reaching out to them to see if that's what they wanted to do and if they wanted to be a part of that care. And for those who don't necessarily have a clinic like that in their area, the best thing to do is to reach out to the surgeons and talk with them and maybe go shadow. It's the same. How do we find who our retina person is? How do we find who our glaucoma surgeon is that we want to refer to? We reach out and we learn, and then start fostering that relationship. And especially if it's a doctor, maybe that an ophthalmologist that doesn't currently co-manage, it doesn't mean it's not an option, right? It's building a relationship so that they understand how it would benefit both them as a surgeon, the patient, and us as the optometrist to really have this big cohesiveness as far as care.
Mm-hmm. And the optometrist has probably seen this patient for years sometimes beforehand. And the surgeon's meeting this patient for the first time as they're pursuing, refractive options and lens implants. I think it's very important that communication happens. And, personalities are interesting. Everyone has a personality, just like an opinion. And how can the optometrist best convey those little nuances that they might have known about this patient over those decades with, exploring contact lenses or refractive glasses rechecks and things like that.
And I think that is so important to do because we are having that more lengthy time in chair. We also are having this longer relationship with them, so we're able to get some of those nuances, as you said. Some personalities are going to be better lended towards different technology lenses than others. Somebody who is maybe not very, they're very perceptive to small changes in their refraction. Patients who are very perceptive to changes in their PALs or their progressive lenses, or maybe didn't do well at monovision, somebody who had issues with multifocal contact lenses. Those are things that they need to know, because that's going to help them decide this, or the surgeons need to know, because that's going to help them decide what lens is going to work well. And I think neuroadaptation is where one of the few places I've seen patients have trouble that we probably could have, if I'd known what other issues they'd had with the progressive lenses and trying monovision, that would be it would have been helpful.
Sure.
And not led to a poor outcome.
Right.
So
poor perceived outcome.
Exactly.
Right?
And it is a poor perceived outcome. Yeah.
Right.
Absolutely.
So how do you manage that with patients? You have to explain the expectations and modify and do that. How do you deal with expectations?
Expectations. Under promise, over deliver. Yeah. So, and being very realistic. Your eyes, we are not fixing it to go back to your 20 or even earlier than 40-year-old eyes, right? We're putting this lens in to get you to a place where you can function. And I want to hear about what your day-to-day life is and where I need to make sure you function. What is the most important thing to you? Your intermediate, your near. Thankfully now we don't have to quite make as many decisions as to say you get either or. We can do a little bit of and. But it's really about having a conversation with, here are the things you're going to experience. Here's what it's probably going to be like. And just be prepared that, no, I'm not going to get you 100% out of glasses. I always say 75%. Would you be happy with 75%? Now, in reality, we may find that it is 95 to 100% that they are not using glasses, but I prefer to set realistic expectations.
So spending 75% of your day out of glasses or other forms of help with their visual acuity.
Yeah,
Great.
Absolutely.
Great. So modifying that, modulating that, and like you said, the optometrist can be such a great part of that journey, explaining, hey, this patient's had a glasses recheck every year I've seen them.
Yes.
They're very particular. We know that maybe that's not a patient that's going to be a great candidate for some of these technologies that might come with some side effects or optical adaptations that may not be what they're expecting, huh?
Yeah. Absolutely. And I think other things we do need to think about too is patients who have other cognitive issues that might also impede their ability to adapt and neuroadapt to it. So patients who have TBIs, patients who have, are potentially on the spectrum, other things that maybe we aren't thinking about that. And the other thing too is making sure that we are addressing any other issues that are going on. So a good comprehensive eye exam, making sure we're checking front, middle, and back. Is there anything on the retina, right? If they have early macular degeneration and maybe starting to develop that, they may not be the best candidate for like an EDOF or something that's a multifocal type of lens. While it may work now, 5 years, we don't know.
Right.
And then other, front surface, we want to make sure we're cleaning up that front surface. So by the time they get to the doctor we're referring them to the surgeon, they have a nice front surface. So when they take measurements, they're getting good data. They're getting usable data, and you aren't increasing the chair time because then they have to step back, fix that front surface before they're able to do all of the measurements that are needed for surgery.
Yeah, that's a great point. That we're putting this lens in, and in theory, that lens is going to be in the patient's eye for the rest of their life. So if the patient's 40 or 90, that lens is in there for the rest of their life, in theory. So we need to be, proactive and screen from, front to back. Yeah. Front mostly being for measurements and good outcomes is what you're really saying, the biometry and addressing that ocular surface. The back more so we predict the future.
It is a little bit, yeah.
So if we're seeing changes back there, if they have, really deep history of macular changes in their family, that might skew the decision making with regards to what lens is best for that patient.
Yeah, absolutely.
What sort of things do you do? What sort of things should our co-managing doctors be doing to look and address ocular surface disease before sending that patient in for the consult?
Absolutely. A good pointed slit lamp exam. I mean, just start with the basics. You're looking at your lashes. You're looking for signs of blepharitis, any signs of Demodex and collarettes. Making sure MGD, what's the level of healthy tear production, and making sure you're getting some stain on there. You need to do fluorescein staining so that you can assess for any smaller things that you might not be able to see to the naked eye, not even just dryness, but going the next step and thinking about ABMD, thinking about any kind of early limbal stem cell problems, and really assessing front to back of just even the cornea.
Right.
Just that tiny little part is so important, because we remember it's 80% of our refractive power, and if something's not going, something is a problem now or looks like it may become a problem, we want to make sure we're getting it to the right doctor first, because if it's something where this patient maybe has Fuchs, do they need to maybe see a cornea specialist first, or somebody who is a cornea specialist and cataract surgeon that can assess, is there any kind of other surgery that needs to happen prior to?
Yeah, that's great. So Cecelia, you have a patient that comes back after a beautiful cataract surgery. You've screened them for all the bad things that might have interfered with that. You've treated their dry eye. You've got the best biometry. You put the best lens implant in, and they come back and they're still not happy with their vision. Now what?
Yeah. So, if nothing else, we talked about checking dry eye before, check dry eye after. We know that the medications that they're using post-operatively and a lot of the preservatives that are in those can actually induce dry eye, as well as the surgery itself with the actual incision has been shown to cause some post-operative dry eye. So making sure, is it still pristine? Are we still doing good? Past that, if they've got any kind of toric IOL, you have to check the positioning. That is definitely one of the important things. Get the patient dilated. Look for the little hash marks. So all of the toric lenses actually have hash marks, and usually in the notes from the doctor, or you can call ask the doctor's office, what was the axis that was put on. So similar to a contact lens, right?
Yeah.
We've got an axis mark. It has an axis mark. So you're going to make sure, is it lined up? I think that's really important and something we can do in office. Past that, you can start to talk about, your vision's not 20/20. The big thing is, are you happy? And if they're like, well, I'm not happy. I'm having trouble functioning. We can start talk to them about contact lenses, going back into glasses. Sure. And depending on their comfort and happiness with that answer, is this somebody who is expecting that they were going to be 100% out? Well, again, we talked about co-managing and managing expectations ahead of time, and that's part of why you want to have those conversations. But we can do treatments on the other side. Mm-hmm. For those who are not happy, and the next steps are, okay, we've got a little bit of astigmatism left or some other refractive error. They don't want to do glasses. They don't want to do contacts. That's the time when you start going back to the surgeon and letting them know. I tend to try to let them know anyway, because they're kind of always watching, and did they hit where they were trying to as far as their refractive error they were going for, and it helps them be better surgeons if they know their outcomes. But they can go back at that point and talk with them about, possibly an LRI or a limbal relaxing incision if for a certain amount of astigmatism. You can also do a post-operative LASIK or a PRK. So essentially they call it an enhancement, right? Sure. Usually. And so that'll treat whatever small amount of residual is there. Now, if you have a toric IOL and it has been rotated, that kind of comes down to the surgeon. They need to make a decision, and it's actually a nomogram that's out there that they plug the numbers into, and it tells them, okay, great, you can do an enhancement, so the LASIK PRK, you can do an LRI, or no, this is not going to work well, they're not going to have good outcome, we need to go ahead and go in and adjust move it, adjust the lens physically.
Sure. So if there's a refractive surprise and somebody's left with something, there's options that are beyond that. And those could go back to where we started, right? Those refractive options, whether it be LASIK or PRK or contact lenses and glasses. Yeah. You've set the expectations, and this patient's 20/20 perfect vision. when they come back and they're still not happy, some people just aren't happy.
Some people aren't. And it's interesting because I've had people where it's one lens in one eye and they have a problem and it's a different lens in the other eye, and something with the material or just them. And it comes down to their brain sometimes. That neuroadaptation typically can take up to 3 months before they're truly neuroadapted. So in those cases, because explantation or exchange is really kind of the last thing we want to do, it's more invasive.
Yeah.
And so we want to give the brain a chance to do its job. We need to give it a time to do it. And there will be some patients who, even if we do give them the time, we've done everything, it just did not fix the problem, and the surgeon's going to make the decision to put in a different lens.
So you're saying be patient.
Be
patient with your vision. Supplement your troubles areas with glasses.
Yeah.
And don't dismiss the patient, right?
Do not dismiss the patient. Make sure that they feel like they've got someone who hears them. Make sure that they feel like they can let you know what the problem is, but also let them know that it is not abnormal for your brain to take time to adapt to things, and that we'll get there. It just may be a little longer road than we originally thought.
Yeah. Thank you so much for meeting with me today.
Absolutely.
And sharing your wealth of knowledge. I really appreciate spending time with you.
It was great chatting with you.